Okay, thank you for asking me to present today. I'm talking today about hypoglycemia in our talk Sweet and Sour, Hypoglycemia in the Newborn. The objectives are the following. I'm going to be reviewing the sweet history of neonatal hypoglycemia, followed by really looking into how does one define and then what does one use for treatment for a low blood glucose in the newborn. We're going to look at the sour challenges and determine thresholds for investigation and management of hypoglycemia in the newborn. And then we're going to combine both the sweet and the sour, and I'm going to take you through our journey, our experience that we had in Winnipeg, Manitoba, in Canada, regarding some changes we made to our approach to neonatal hypoglycemia. And this may surprise you, but in the end, I will not tell you exactly what to do, but I will certainly give you some pause for thought. So I think the first thing that one needs to think about is that persistent neonatal hypoglycemia is something that is caused by something pathological. And we differentiate that from that which we consider physiologic, which is the normal drop in glucose which one sees in the first 48 to 72 hours. It is difficult sometimes to distinguish persistent versus transitional. But what we do want to emphasize, or I do want to emphasize here, is that if you do have true persistent neonatal hypoglycemia in the newborn, we do want to treat it in order to prevent negative effects on development of that newborn. Having said all that, the cutoff threshold is controversial, and I'm going to show you in a few slides as to why that probably is. And then when we're trying to determine what the cutoff is, one has to think about, are we using the presentation of clinical manifestations as reason to treat, or are we looking at physiologic response? So when you're thinking about hypoglycemia and developmental delay, there's lots of questions that come up, such as, is it the duration of hypoglycemia that's important? Is it the disease? Is it the specific level? When we think about specific disease, conditions of persistent hyperinsulinemia or congenital causes of hyperinsulinemia are known to have adverse developmental outcome as a consequence from persistent and prolonged hypoglycemia. But what about outside of those? What about the otherwise normal child who has a few episodes of hypoglycemia? There's lots of literature out there, and due to time constraints, I certainly don't have the time to present all of the neurodevelopmental outcomes, but I have picked a couple studies that I think are important to look at. So one of them is quite old now. It's over 30 years old and involved, it was from Alan Lucas, and looked at 661 preterm infants who were under 1,850 grams, as you can see. The importance of this study was that they did define a glucose of under 2.6 millimoles per liter as being significant. When we looked at the outcomes in this study, really what you needed to have was more than 5 episodes in the first 2 months were associated with developmental delay. And more importantly, or equally important, when you looked at where hypoglycemia in terms of days of hypoglycemia started to become significant in terms of an adjusted relative risk for versus non-hypoglycemic episodes, it was after 3 to 4 days that you start to see that kids with persistent hypoglycemia are at risk. And so that 72-hour threshold is important, and we'll come back to it later. The other study that's worth mentioning is by McKinley, and McKinley looked at the sugar babies cohort. For those of you who are aware, Dr. Harris has studied the use of glucose gel, and in this cohort of 528 infants, half of whom received dextrose gel versus half who did not, they tried to maintain a blood glucose of over 2.6 millimoles per liter for up to 7 days. Importantly, they used some continuous glucose monitoring and identified that about a quarter of the babies in this cohort had undetected, meaning point of care did not detect hypoglycemia, and those babies did not have an increase in developmental delay. And importantly, if you look at the forest plot, you can also see at different glycemic thresholds, really compared to the euglycemic cohort, you didn't have any impairment of, or any difference in impairment of the effect of having hypoglycemia. It's important though that we distinguish, and we're going to come back to this later, the fact that there's no difference in risk of impairment versus whether they have any impairment at all. And so we'll talk about that in a bit. But when you go back to where these thresholds, whether it's 2.6 or 3.3, where these come from, it's very interesting that, we debate this some 55 years later. We're still debating the same thing. This is from August 12, 1965 by Dr. Kornblath. And what he says is extensive literature exists. There is still disagreement over which level of blood sugar is normal in the neonate and which are hypoglycemic or hyperglycemic. Interesting that we were debating this so many years ago. From the study, when he looked at, these were generally healthy prems and term infants, and what he found was, and this is quite interesting, is that in the first 48 hours to 72 hours, and you can see this is the 48-hour cutoff, and here's the 72-hour cutoff, what he found was that the threshold for the prems was they tended to have a blood sugar around 2.8 for some time, whereas the term infants, you can see that by the time, from the time of birth, they pretty much are at 3.3 millimoles per liter, but they start to rise after that. Between 48 to 72 hours, they rise. So we do know that it's normal to have a lower blood sugar in the first 48 to 72 hours, but this is where some of these numbers come from. So what do we do? How do we know what is the appropriate blood sugar to rely upon? And for that, we turn to places like the Canadian Pediatric Society, or we turn to the American Academy of Pediatrics. And then lastly, we have from 2015, the Pediatric Endocrine Society that weighed in on this and tried to determine what was appropriate. So what do they say? Well, the Pediatric Endocrine Society, this report was released with a lot of fanfare. The reason was because it really attempted to address the period in the 48 to 72 hour range and afterwards, which the other documents hadn't really addressed. What they talked a lot about was physiologic neuroendocrine responses as opposed to clinical symptomatology. So when did you start to see changes in cortisol? When did you start to see changes in growth hormone and so forth as a response to a low blood sugar? They also looked at recommending before 48 hours using a value of 2.8 as your lower threshold, and after 48 hours using 3.3 to as high as 3.9. And they also recommended a 6-hour fast prior to discharge. And the 6-hour fast does have some rationale in that the idea is if you are discharging a patient who has quite brittle blood sugars in terms of control, one wants to know if the family was to sleep and let the baby sleep for longer than 3 to 4 hours, are they going to develop significant hypoglycemia and develop a seizure? Excuse me, in Winnipeg we took this information and actually adopted the change in practice. And so we'll go into what happened. But in summary so far, the CPS has essentially said in the first 48 hours that a level of under 2.6 is treatable. The AAP is under 2.5 and the PES is under 2.8. But the PES also brings in 3.3. Having said all that, when you look at the body of text of all three documents, and I won't read this all out to you, but they still are vague. Even though they've provided us with numbers, what they all say is that it's hard to actually pinpoint a single value. So it really does speak to the ambiguity around what is supposed to be treated and what doesn't need to be treated. Another fly in the ointment is obtaining samples. When we do point of care glucose monitoring, it's really important for everyone who's involved to remember that whole blood can be 10 to 20% lower than plasma. And what that means is your point of care blood test at the bedside may have an error by as much as 0.3 to 0.6. And what that means is that if you, and I'm sure this has happened to many of you, if you get a blood sugar under 2.6, let's say it's 2.5 and you send it to the lab, if you can have a 20% error, then you might actually get a value back from the lab of 2.8, which makes interpretation of any of your measurements in terms of things like beta-hydroxybutyrate, insulin levels, problematic because the sugar is actually normal. More recently, we've also seen exploration of the use of continuous glucose monitoring. There is often a lag of anywhere from 10 to 20 minutes comparing the interstitial glucose to that which is in the serum. And there are practicalities for use in small infants, but this has been done and there are results out there that one can look at. But suffice to say, at least here in Canada, this has not become the standard of care. When we talk about getting a critical sample, certainly I usually recommend a level under 2.8 for investigation, but we look at, due to the risk of error as I mentioned, but the things that we typically send will be beta-hydroxybutyrate and insulin level, growth hormone, cortisol. Other things looking for metabolic disorders will depend on your institution and what the prevalence is of some of these conditions, but you can also order gases, free fatty acids, or carnitine. So what I mentioned the local Manitoba experience. So back in 2014 and 2015, some changes occurred to the way we manage hypoglycemia. The first was that we started a protocol as we were starting to see increased use of diazoxide, which has counter-insulin properties, and then indicated that we should start endocrine consults as a routine practice when we're going to use diazoxide. We also collaborated with neonatology and endocrinology to adopt the PES guidelines, which I mentioned used a threshold of 3.3 after 48 to 72 hours. And that's precisely what we did. But we decided on 72 hours rather than 48 hours as we had some concerns about having inappropriate admissions for transient hypoglycemia rather than the more persistent cases which we were trying to identify. The other thing was we implemented a 5-hour fast. The 6-hour fast to us seemed arbitrarily too long, so we went with 5 hours. So we would test AC blood sugars at 3 hours, 4 hours, and 5 hours, and if they passed that, they could go home. So what we found was we had 56 infants during this period. The vast majority of them, when you look at their diagnosis, had hyperinsulinemia. The other thing that we noted, and I have there in yellow here, is that when you looked at the mean and median blood sugars that were actually identified in these hyperinsulinemic children, they all were under 2.6. So even though we increased the threshold to 3.3, you might find more babies with abnormal glycemic control, but in terms of what the actual numbers are that are going to present if they have true persistent hyperinsulinemia, the levels are going to be lower. And you can see about half of these kids were treated. Interestingly, most kids were treated for about 3 months until their glycemic control improved. So we really found no difference before and after we instituted this in terms of diagnosis hyperinsulinism. We really didn't find a change in treatment with diazoxide. We did start to wonder if we were just investigating more kids, or perhaps would we see a difference in rates if we if we had more babies in our cohort. But it's just interesting to share with you that one thought we might have seen a whole lot more diagnoses, but really the percentage of infants with true hyperinsulinism did not increase, and probably because we're just observing, we're not influencing, of course, the frequency of that condition. So let's talk about the sour. So that was the sweet, some of the great changes we made. So the sour. So in terms of recipes for treatment, this is what we typically think of here in Winnipeg. We encourage breastfeeding and skin to skin. We think about increasing volume of feeding or fluids when managing hypoglycemia. We do use glucose gel. We change the frequency of the feeding. Sometimes we'll feed the babies every 2 hours, or put them on feeds over an hour. We'll put them on continuous feeding. Peripherally, we use anywhere from D10 to D20. And then the options below that for persistent hypoglycemia are shown. The one we typically use here is diazoxide, but certainly other centers will use things like glucagon as opposed to growth hormone. And I have seen people use hydrocortisone. But talking about diazoxide, as I mentioned, does have antagonistic effects to insulin by inhibiting the secretion of insulin. What we find, though, there are two types of babies with hyperinsulinism. They're the ones that are very clearly hyperinsulinemic with insulin levels in the hundreds, but then there's the ones that are inappropriately detectable, and I'm sure you've seen these, where you draw blood sugar, the sugar is 2.2, and you get an insulin level of 8. The insulin level really with a sugar of 2.2 should be effectively 0 or 1. So that is an inappropriately detectable insulin level and something that we would treat. We do know it works quickly, often within 1 to 2 doses. We do see it reduces the number of pokes. However, in July 16, 2015, about the same time as we introduced diazoxide for use in the region, the U.S. Food and Drug Administration sent out this warning documenting that there had been 11 cases of pulmonary hypertension since 1973, and they suggested that perhaps this is a legitimate side effect or adverse effect that one needs to watch for. So we decided to look at our own experience, and we were surprised that, with the small cohort of patients that we had, and I'll show you the rest of the results on the next page, and this was presented actually back in 2016, I believe, at the Pediatric Academic Society meeting. We actually had 4 kids with hypoglycemia who were treated with diazoxide and developed pulmonary hypertension. And what we found was the larger kids were the ones that tended to develop risk of pulmonary hypertension. We also found in yellow here that the kids on higher doses, so once you were over 10 milligrams per kilogram per day, the risk was statistically significantly increased that you wound up with risk of pulmonary hypertension. The Japanese have previously published that they believe this is related to fluid retention and had documented as much as 73% in a case series. But in that case series, they had used a dose that was over 2 times as high as our pulmonary hypertensive group. So perhaps it's not surprising. And I do know from speaking to various individuals in the neonatal community that there are centers who do use diazoxide who, as a routine practice, give Lasix when they start it. So that's diazoxide. Now I'd like to move on to glucose gel. For those of you who, if you use glucose gel, you'll know this probably already, but for those who don't, it's worth mentioning that when we give 0.5 mils per kilo of 40% dextrose gel in the intrabuccal mucosa, that's the same as giving a 2 mil per kilo D10W bolus. Both provide 200 milligrams per kilogram of dextrose. And this formed the basis of the Sugar Baby study, as I mentioned, back in 2013, which was a double-blind RCT of dextrose gel versus placebo. The primary outcome failure here was, for the first 7 days, to have a blood glucose less than 2.6 after 2 treatments. When you look at the outcomes of the study, what you found was the risk of treatment failure, so having 2 blood glucoses still under 2.6, was higher in the placebo group than in the dextrose gel group. What was not significant, though, was the overall admissions. That might not be surprising because infants who are born to mothers with, let's say, diabetes might have more risk of TTN, RDS, and so the overall cause of admissions were not influenced by the use of dextrose gel. But when you looked at the secondary groups, when you looked at admission for hypoglycemia, we see that there's almost a halving of risk of admission, and that was statistically significant. The other bonus here was that at 2 weeks of age, the risk that a patient would be receiving formula was 13% versus 4%, and that was statistically significant. So it's surmised that the reason for this benefit was keeping mums and babies together with the use of dextrose gel allowed for more bonding, more skin-to-skin, and better breastfeeding rates. I had mentioned that when they looked at the long-term outcomes of these patients, that the risk of neurosensory impairment was no different, and that's true. It was 38% in the dextrose gel group and 34% in the placebo group. But I mentioned that we would come back to this because what was concerning about this is, why is there any neurosensory impairment? Now, most of it is mild. 31 out of the 38% was mild versus 33 out of 34. But if we're keeping the blood sugar above 2.6, shouldn't these babies be normal? So they are puzzling. One possibility to think about is that the placebo group waited up to 1 hour or 2 feeds to address properly. So shouldn't the gel group be better? Why wouldn't you be better if you had more prompt resolution of your hypoglycemia? Could it be the conditions themselves? Is there something intrinsically wrong, or is there an impact on development from being a late preterm, which we know there are some studies indicating that, being IUGR or IDM? And the final thought is, and this needs further exploration, because these infants were maintained with a blood sugar goal of 2.6 for the first 7 days, is that part of the problem, that if you're still having sugars of 2.7, 2.8 7 days out, does that have an adverse effect on the brain? So as I mentioned, we had adopted the PES statement, and this was a bit shocking to all of us because we adopted the PES statement, and I received some pushback from colleagues who felt that we really didn't have adequate evidence to go to a threshold of 3.3, and they were worried about increasing our rates of admissions. And so when I looked at this with a colleague, we went back to the statement, and really the gurus of hypoglycemia in the United States wrote this statement. But when we reviewed the statement, went to the references, we uncovered several problems. None of the quoted papers actually included neonates, and the main argument for normal misstated 2 days instead of 2 years. And this was from a book that was on children with diabetes that were looked at from 2 years to 17 years, and the evidence was that a threshold under over 3.3 was warranted based on this, but these were not neonates. The other thing was the neuroglycopenic thresholds were all to produce symptoms were also derived from a book on diabetes in children. And lastly, a very key reference to making the argument for increasing the threshold glucose to treat was based on the assertion that neonates were more susceptible from the effects of hypoglycemia to neuronal injury, but when I pulled the reference, it was the opposite. Neonates are actually less susceptible to neuronal injury. And if you go back to the study by Kornblath that documented normal glucoses in the first 72 hours, you'll remember that the normal prem tended to have sugars around 2.8, so that would certainly fit with what's normal. So we went actually to the authors, the principal authors of the statement. We actually emailed them, and these are the comments that they made. We tried to avoid the numbers game of defining hypoglycemia by a specific number. There is no magic number. They said the whole point is that you should not be testing normal babies, so you should really just be identifying abnormal at-risk babies. They acknowledged the evidence either way is lacking, and they wanted to make sure babies were safe to go home. So before I discuss this slide, we have to then, acknowledge that there's a lesson learned here. Just because you have very influential authors writing a paper doesn't mean that you should just take what they say verbatim. Go back to the sources and check for yourself. However, to address the concerns of my colleagues, we looked at the effect on admissions. So remember in late 2014 we introduced diazoxide. In 2015 we introduced the change to a threshold of 3.3. And what you'll actually see, and that's where we introduced in December of 2015 the change in threshold, the overall admissions, dropped over time. And we suspect that that was related not to going up to 3.3 as a threshold, but we suspect that's the effect of glucose gel. That with the introduction of glucose gel, as they saw in the Sugar Baby study, even though we went up on the threshold to 3.3, the sugars came down, the admissions came down. And I think that again speaks to, even though you're increasing the threshold to 3.3, what that's doing is it's allowing you to pick up additional babies who have persistent hypoglycemia. The ones who have transitional hypoglycemia will have sugars above 3.3 after 72 hours. So we do believe that has been a safe change. And that just shows the drop in admissions. So finding a path forward. So this is what we do. Prior to 72 hours, we continue to use a threshold of greater than or equal to 2.6. And while the PES advocated for a 48-hour cutoff, given the author correspondence quoting they accepted 48 to 72 hours, we went with 72 hours. After 72 hours, our goal really is to identify what is the cause of the persistent hypoglycemia, and for that reason we do send critical samples, but only if the blood sugar is less than 2.8. And the reason for that, again, is because of the error potentially in the point of care testing. Our other goal is to keep families and babies together for bonding. We really try to avoid over-investigation, which we get by only although we have a clinical threshold of 3.3 or more, our investigation threshold is under 2.8. And we want to prevent admissions, and we have shown that our admission rate has dropped. And so point of care testing is generally what we do, but we certainly want to minimize the number of pokes. So that's why we've balanced safety with over-testing by having differences between therapeutic targets and thresholds for investigation. And I can't stress enough that you need to obtain critical samples which can be interpreted. So we moved away. At the beginning, if a baby had a glucose of, let's say, 3.2 or 3.1, we were sending off critical samples. But then when we got an insulin level back of 15, but the blood sugar also came back at 3.8, it left us scratching our head because that would be appropriate. After 72 hours, we do try to keep the blood glucose greater than or equal to 3.3. We do, in fact, only investigate if it's under 2.8, and that does allow for the error in 20%. Having said that, we also do, it says 5 to 6, but it's really more of a 5-hour fast, although some centers will do a 6-hour fast, and we do try to maintain the glucose above 3.3 to ensure safety for discharge. Especially because in our center, about 40% of all of our neonates come from outside the city of Winnipeg, and so we are concerned if they were to become hypoglycemic in the periphery, they could have a very long drive to get health care. So conclusions. Developing protocols can be sour, as we experienced a lesson in taking experts' advice for granted. Collaboration with colleagues is less sour, and it can be sweet. We do feel that the 3.3 millimole per liter cutoff for initial workup may be too high if in terms of under 72 hours or under 48 hours. But a monitored fast with the aim of 3.3 ensures safety prior to discharge. And this is perhaps one of the strongest safety comments here, is that if you are going to use diazoxide, we certainly advise waiting till after a week of age, given the side effect profile. The risk of pulmonary hypertension is likely quite small, but given that it is present, it's something that warrants some consideration before starting it. And that's the end of the conclusions, and I can only add that a CPS revision, so the Canadian Pediatric Society revision to the previous statement on hypoglycemia, should be out this September or October. So look for that as we look forward to sharing that with the rest of the world. Thank you for your time today.